In the last video, I talked a lot about the neurodevelopmental assessment of children. What I'm going to talk about in this talk is about an approach to a child whose conscious level doesn't seem right for that child's normal stage. In other words, altered consciousness in children can be really hard to assess because in an adult, you would have a standard approach. You might do a mental states examination and a Glasgow Coma scale, and you'd very quickly have a sense of where this patient was in terms of their conscious level and their communication and their interaction. And children, it's often very difficult because obviously this changes with age. And as I described in the first couple of talks, we really have to know where a child is in terms of their normal development and behavior. And in the last talk, I really talked about thinking about what would a normal child of that age be like and how does this child compare with that? Fortunately for us, the AVPU, the alert responding to voice, responding to pain only, or unresponsive scoring system works pretty well for any age. And I suppose really what I'm going to be talking about for the rest of this talk is what to do with a child where we're concerned about their AVPU. We can finesse this down to the GCS, and there is a pediatric Glasgow Coma scale, and we would generally want to use this to finesse that assessment down, particularly for situations like a head injury, for instance. But in terms of the acute assessment of a child where we're concerned about their conscious level, the AVPU will work in a small baby who is either alert and crying or responds to voice or is only responsive to pain or is unresponsive. And that would work for pretty much any age. And the question is, why would a child have a reduced level of consciousness? Now, if I'm going to think about this problem, I've got to think about it really in terms of two basic problems, I think. Either this is a primary brain problem. In other words, there is an issue with the brain's ability to function normally that is coming from a problem with the brain. Or there's the brain is basically normal and healthy, but something is going wrong with the perfusion of that brain or what it's been perfused with or what it's being given that is meaning that it can't work normally. And I think I'd really like you to hold that concept in your head, as well as remembering the fact that children will present with all sorts of unusual, peculiar illnesses as their first presentation. Every child with a neuromuscular problem, a neurodegenerative problem, a enzymatic degenerative disorder, a child with a brain tumor, or an epilepsy syndrome. All of those children will have to have presented for the first time to a clinician. All of the children with some metabolic problem that mean that they are prone to having very high levels of ammonia or very low blood sugars. All of those children will have presented for the first time to a clinician, and they may well present to you, and they may well present with altered consciousness. Now, fortunately, these children present less frequently than they used to because of the 5-day Hill prick screening out a lot of serious, important metabolic conditions. But nothing is perfect. And we have to have an approach to a child with reduced level of consciousness that is mindful of the fact that there's going to be a very different differential for primary brain problems or problems with the blood supply and what's been supplied to that brain. Fortunately for us in pediatrics, we have some brilliant guidelines, and they're called the DCON guidelines. The Royal College of Pediatrics has brought out some fabulous guidelines for children with reduced conscious level. And if you go back to the Southampton and Oxford Retrieval, the SORT guidelines, and have a look at their guidelines for management of reduced conscious level, and also have a look at their guidelines for managing the child with a seizure, because this is going to be the resource that we will use when we see a child with reduced conscious level. If I'm going to think about a child with reduced conscious level because of a seizure, well, again, this child might have a primary brain problem or have a problem with the perfusion of the brain or what the brain is being perfused with. And so the management of seizure and the management of reduced conscious level are often very closely linked because the causes of them can be very similar. And the way I would think about a child coming in with a fit and the way I would think about a child coming with reduced conscious level is often very much the same thing, because I'm thinking, well, what's going on inside the head to cause this reduced conscious level or to cause this fit, and what's going on outside the brain that might be causing the brain to malfunction and cause the fit or cause the reduced conscious level. So if I'm thinking about things inside the brain, well, this child might be having a fit because they've got an epilepsy syndrome. And we need to understand that there will be children presenting with epilepsy syndromes or children presenting with fits for a more mundane, I suppose is the word, cause, namely febrile convulsions. And we will see children with febrile convulsions quite commonly, and you need to have looked at the Wessex Healthier Together information sheet for parents on febrile convulsions and be able to think about and talk about febrile convulsions if you're going to be looking after sick children. There will be other brain causes for convulsions, and these might include other intracranial problems. And I suppose the way I think about intracranial problems would be to think that there might be a mass or a lump, and this might be a tumor or a growth or an abscess. There might be some kind of infection like a meningitis or an encephalitis, or there might be some vascular problem such as a stroke with a bleed or a clot. And so I would go into this thinking, well, is this going to be some kind of primary epilepsy syndrome? Is there going to be a mass or a lump or a growth? Is there going to be an infection, or is there going to be a vascular problem? Or is there going to be something like a, more obvious, like a traumatic brain injury or something where the history would suggest this? But very much in those children, what I'm thinking about is stabilizing them from an ABCD point of view and doing investigations, including cross-sectional imaging. Whereas the children who've got reduced conscious level or seizures, not because of a primary brain problem, but because something outside of the brain has gone wrong, the way I would think about this is either there is a problem perfusing the brain, and that might include heart rhythm problems or heart problems, meaning the blood pressure is low. Or it might be that this child has had a faint, has had a vasovagal episode or a syncopal episode, and for that period of time was just not perfusing their brain normally, and that's why they've had reduced conscious level. So I would think about perfusion and blood pressure, and then I would think about what's actually in the blood. I would think about things that shouldn't be there, like drugs. Has this child managed to ingest a drug? Or too much ammonia because this child's got a metabolic or a liver problem? Or not enough of something, not enough sugar, not enough salt, not enough calcium. And so if I'm going in to see a child with altered consciousness and or seizures, this is the approach that I've got. I'm going to want those guidelines, those DCON guidelines, the reduced conscious level guidelines, and I'm possibly going to want the seizure guidelines as well. I'm going to think about things inside the brain, and I'm going to be very attentive to the possibility of raised intracranial pressure and needing to manage that and thinking about raised intracranial pressure. But I'm going to think about problems inside the brain and what sort of tests or investigations or treatment I might need. And I'm going to think about problems outside of the brain in terms of the perfusing pressure and in terms of what's in the blood, in terms of extra things that shouldn't be there or things that are missing or low that should be there for the brain to function well. Finally, I'm going to try and wrap this all together and think about the child as a whole. In other words, does the child have any other signs of injury? Does the child have any other signs of infection or sepsis? Does this child have any other signs of a bleeding problem or a bruising problem, or severe anemia or shock or sepsis or something else that might need to help me to understand what's going on causing this reduced conscious level? The differential diagnosis is vast. And so what we need to be able to do is to be able to do this very rapid, structured ABCD, stabilizing the patient whilst we're thinking about things that we might need to test for, treat for further investigations. This is quite a complex process. It needs quite a lot of people around the child, but you as a clinician who's going to be looking after sick children need to have this very basic approach so that if you're going to see a child with altered consciousness or a child with a seizure, you can be instituting those ABCD initial investigations, initial life-saving interventions to stabilize whilst you're waiting for help.